Good morning, ladies and gentlemen. This is Aisha Shehi from the National Insurance Company Daman, and I am part of the disease management team. Thank you for joining us today in our webinar, Understanding ADHD Across Different Age Groups. Understanding ADHD is important for creating supportive environments at home, school, and in the workplace. As awareness continues to grow, so does the need for accurate information and practical strategies. Now, please join me in welcoming our speaker today, Dr. Habib Abdullah from M42. Dr. Habib is a US trained and licensed consulting clinical psychologist with over 12 years of experience in the USA and UAE. He specializes in sleep disorders, trauma, and stress related conditions, and the relationship between physical health and mental well being. Please note that you can send your questions through the Q&A chat box anytime during the session, and we will allocate 15 minutes at the end to answer your questions. Dr. Habib, welcome. The floor is yours.
Thank you, Aisha, for the kind introduction, and good morning, everyone. Let me just quickly share my slides. I'm going to turn off the camera quickly while I do the presentation so I can get closer to the mic. This morning, we will be talking about understanding ADHD across the lifespan and how it impacts throughout the different stages of life. Just a quick overview for our agenda. We will discuss what ADHD is, what are some of the core symptoms that looks like, how is it clinically presented, comorbidities, and then how ADHD impact different life stages for us. We will just briefly touch on the neurobiology as that is something to discuss in another presentations. And then I want to close up with just how we do an ADHD assessment and intervention across different age groups. So that gives us more perspective on it. So let's start with the definition. What is ADHD? This is a very clinical definition. ADHD is a neurodevelopmental disorder of self-regulation characterized by persistent pattern of inattention, hyperactivity, and or impulsivity that interferes with your academic, social, emotional, or occupational functioning. So this is how we clinically define ADHD is part of the neurodevelopmental disorders and how it impacts us. Now, what I ideally like to describe things is more in a journal language for us to understand. So how do we define ADHD? From a day-to-day perspective. ADHD is a brain-based condition that affects an individual's ability to regulate attention, behavior, emotions, and executive functioning skills. A lot of the time in our conversations, we miss the emotion part of it, that ADHD impacts people's emotion. When people go through different emotions or when they express emotion in a different way, we don't realize that maybe ADHD might be the impact of it. Now, it's very important to know that it's not simply behavioral problems. And it's not a result of poor parenting. Rather, it's associated with difference in the brain development in neurochemical regulation. This is one of the most common thing that we see in assessment when a child comes for an assessment and parents believe that either a child have a behavioral disorder or it's because they have not been parenting well. So once we reach a correct diagnosis and kind of do the psychoeducation aspect of it, this is the main thing we usually work on. And it makes a big difference in the management part. We will discuss that further as we look into different interventions. Now, in terms of core symptoms, ADHD involves chronic inattention, hyperactivity, and impulsivity that affects daily life across different settings. Again, we know it's a neurodevelopmental roots, so there is different brain-based differences that affects executive function and neurochemical regulation. And again, it's not like a childhood and a disorder, but symptoms starts in childhood and often persists in adolescent and adulthood, affecting multiple life aspects. So sometimes you might get diagnosed when you're teenagers. It's not very uncommon that we are diagnosing even adults in midlife as well. Sometimes people reach their 30s and even 40s, and then when they realize that a lot of difficulties that's happening is they might have something undiagnosed that they need support for. Again, it's a spectrum and functional impairment. So ADHD symptoms varies in types and severity and can cause functional impairment in academic or social life. So it's not a condition that affects you only in school or during college time, but it impacts changes and varies depending on where you are in your life. As we know, the core symptoms, the first one is inattention. So I think this is very commonly people know that difficulty sustaining attention, easily distracted, being forgetfulness, poor organization, frequent losing items, difficulty following instruction or completing tasks. So when we see anyone struggling with one of these difficulty, we believe that they have difficulty with inattention. The hyperactivity, excessive movement or fidgeting, difficulty remaining seated, restlessness, excessive talking. So that's the presentation of the hyperactivity aspect. And then there is something which is part of the ADHD, we call impulsivity, which is acting before thinking, interpreting others, difficulty waiting turns, making hasty decisions without considering consequences. Now, one thing as we go through this presentation, I want us to keep in mind as we all have some of these difficulty in our day-to-day life, which is very normal. Remember, just because one day it's hard for me to focus or I forgot something does not mean I have inattention or ADHD aspect. But if it happens on consistent pattern and it's impacting my day-to-day functioning, that's where we actually pursue an assessment and kind of go from there. So just having one or those symptoms once in a while does not qualify for or does not get requires an assessment and diagnosis. Again, the inattention symptoms that includes difficulty focusing, organizing, or following instruction, and often cause forgetfulness and careless mistakes. We see this a lot for kids in school where they understand the material, but they have been missing information or making mistakes. Adults having their job or life is being impacted because things have not been paid enough attention to, and it happens on a repeating pattern. Hyperactivity, which again involves excessive movement, restlessness, difficulty seating, and especially acquiring calm behavior in situations. So this is mostly we see in classrooms, which is more regulated rather than workplaces. And then the impulsivity traits. Again, if you notice, we call inattention as symptoms, we call hyperactivity as characteristic, and impulsivity traits. It's more of a trait where you are acting without thinking, interpreting others, trouble waiting, or making a hasty decision affecting social life. We also see this, especially in adults, where they make business decision without properly thinking through the consequences and then having suffering from that. So again, it becomes a trait that affects them on day-to-day functioning. Again, symptoms vary by age. Hyperactivity is more common in children, while inattention persists in adolescent and adulthood. So even as a child, if there are complaints or concerns of hyperactivity, when you become adult, you learn to cope with that, but it kind of plays out more in inattentions in your relationship. In terms of clinical diagnosis, we have 3 types of ADHD. So the first is inattentive type, or the inattentive presentation, which is again characterized by difficulty in sustaining attention, organization, following through. This is often undiagnosed, especially majority in females due to the lack of disruptive behavior. But generally, clinically, this is one of the hardest one to diagnose. The reason for that is not from the clinical aspect, but in terms of help seeking. So a lot of these kids who have inattentive type ADHD, they are either being labeled lazy or kind of different labels have been put on them by parents or teachers, and they rarely get escalated to seek help. But when they do, it makes the life of a difference for them. The second one is the hyperactive impulsive presentation, which includes excessive movement, restlessness, and impulsive action, typically seen in structured settings like classrooms. These are the kids, they get into a lot of trouble, they get a lot of timeout. They usually end up for a clinical assessment much faster because they keep getting into trouble and getting flagged by parents and teachers. And then the last one, which is the combined type, which is most common form, showing both symptoms of inattentiveness and hyperactivity impulsivity type. From a clinical perspective, this is not the most common one. I would say it's the most commonly diagnosed one. And again, it's because they're inattentive, so their grades are falling, but they're also hyperactive impulsive, so they're getting into trouble. So their grades are not doing well, their behavior is not helping them, so they are being escalated to seek help. So that's why they're being diagnosed most common. And one of the most important thing is it has to have individualized care plan. So dynamic ADHD presentation requires ongoing assessment and tailored intervention to support diverse needs. If someone is struggling only from inattention, they need different kind of support than someone struggling with combined type or hyperactivity. Impact and comorbidity. So one of the most common impact, as you can expect in kids we see, is academic difficulties and behavioral challenges in school. So if someone only have inattentive type, the grades are falling. If someone has combined or hyperactive type, they get into a lot of behavioral challenges as they become older, and we'll talk about how it changes through the life stages. Then there is a social and emotional impact. ADHD can cause social difficulties and emotional stress. When you have social challenges, of course, it leads to peer rejection, then kind of escalates into lower self-esteem, and we can also see some comorbid anxiety with the ADHD. Sometimes we see a child in clinic for an anxiety assessment, and then we realize that anxiety is caused by the ADHD and the social challenges. So it's like a bidirectional relationship. Some of the most common comorbidities are oppositional defiant disorders. Usually we see in young children and teenagers. So they become oppositional. So it's not an ADHD hyperactive type, but it's more ODD. So proper assessment is needed for that. Learning disability is the most common one. Someone who has dyscalculia or dyslexia, and they're not being able to do their work. And sometimes that's not been diagnosed, can be labeled as ADHD. So that is also a very common one. And then anxiety, it complicates ADHD. But the general most common one, which is recommended to kind of assess for or look for differential diagnosis, is the first one is learning disability, very common. The second is trauma-related disorders. I have a little bit slides on them because those are very important, especially for adults, that sometimes trauma-related disorders are misdiagnosed as ADHD. ODD, as we talked about, anxiety disorder, depressive disorder, autism. There is a big comorbidity between autism and ADHD. So that also needs to be assessed if there is comorbidity or if it's a differential diagnosis in ADHD assessment. Sleep disorder is another common one, which has been very commonly misdiagnosed as ADHD. And I have a little bit information on that, as well as I believe strongly that it needs to be taken into stronger consideration when we're seeking ADHD assessment. Tic disorder, emotional dysregulation, and then substance abuse. So these are something we need to kind of either look for as a differential or if it's comorbid with the ADHD. Now again, ADHD affects individuals from early childhood through adulthood, impacting cognitive and emotional functioning. It's a lifelong neurodevelopmental disorder. Again, while symptom often changes with age, the impact can be seen across academic, social, emotional, occupational, and family functioning throughout the life. ADHD commonly evolves from prominent hyperactivity in children to executive function difficulties and internal restlessness in adulthood. So again, sometimes people believe that, and you will hear this common phrase, people saying that, well, I think I had ADHD when I was a child, but not anymore, it went away. It doesn't really go away. It just kind of changes the presentation and the impact it has on our life. And that's where we have to see if it's impacting us significantly, that we need to kind of seek a more formal evaluation for it. So let's look from younger children, from early childhood, age 3 to 6 year old. You would be surprised how many parents show up before the age of 2 or 2.5 in clinic asking for ADHD assessment. And I have to give them psychoeducation that let's wait until 3-year-old and then look into the behaviors, and then we can do the initial screening. But because the knowledge is there, people are understanding ADHD more and more, but with not having enough information about it, sometimes parents will seek a much earlier assessment. But generally what we recommend is to look from age 3 to at least age 3 to look for symptoms. So for a 3 to 6 year old, what are some of the common features we might see? Excessive activity and restlessness, difficulty following instruction, short attention span, impulsive behavior, frequent tantrums, and emotional dysregulation. The reason we pick 3-year-old is at this age, they should be out of something, as you might have heard about terrible twos, where they throw severe behavioral tantrums with or without any visible trigger. So after the age of 3, when they are throwing these tantrums, that's when we look into, are these tantrums or is it something related to impulsivity or hyperactivity? So these are some of the most common features you see. The impact of it, remember we talked about it's not just a symptom, but we also have to look at where it's impacting. So the impact is difficulty participating in structured preschool activities. That's one of the most common area to flag initial concerns and send referrals are preschools or nurseries. Increased paternal stress. The parents are seeing their kids growing up, but the behavior is becoming harder and harder to manage. Challenge with peer interactions. These kids have hard time following direction in the preschool activities, but also kind of playing well with other kids or sharing. And we're not talking about a social disorder, but more of a behavioral problems or challenges. Earlier behavioral concerns at nursery or kindergartens. That's where mostly it's lack. So whenever a parent comes in the beginning of the assessment, the first question is the school or the nursery or the kindergarten reporting similar concerns? You would be surprised how many times, at least 50% of the time, the parent says no. And that's where then we kind of look into other things that might be happening, that might be impacting the behavior rather than in ADHD, because it has to be in 2 or more settings. The next age group is school age group, 6 to 12 years old. The common feature in this age is inattention and distractibility. They have poor organization. We see a lot of hyperactivity in classroom and impulsivity and interruption. These are the kids who gets a lot of timeout. There's a lot of parent-teacher meeting regarding behavioral problems, a lot of home conflict because of the complaints before they seek a formal evaluation. Now, the impact is academically, the grades decline despite being intelligent and being told that your child is very smart, but the grades are not reflecting. So we need to look into what's happening. A lot of the time, homework is incomplete. So again, remember we talked about the differential between oppositional defiant disorder, ODD, and ADHD. So this is a key differential that helps me see, is the child refusing to do homework? Or is the child doing homework, but they're not completing it, or there's careless mistake? So that's where, when we talk about differential as a clinical psychologist, our brain works in kind of seeing that, okay, do we need to pursue an ODD evaluation, which is a behavioral disorder, or do we need to look into more of the neurodevelopmental aspect of ADHD? And then they have difficulty following multi-step instruction. So these kids, when you give them simple instruction, they do very well, but when it's more, they have hard time following those up. And we'll talk about what are the interventions for that. But again, this kind of clearly differentiate between a behavioral disorder where the child refused to do what has been asked and very oppositional, versus they are doing it, but not very successfully. At this age, remember, after the age of 6, the social world start opening up for you. So there is, if the child is struggling with ADHD, we start seeing early challenges or difficulty of social difficulties. So there's a lot of peer rejection because they're not able to pay attention to their friends, or not being able to wait their turns or share, friendship difficulties, and then frequent conflict at school. Because of the impulsivity, they get into conflict with friends. At home, at family level, there's a lot of parent-child conflict because either they're talking back, they're not paying attention to things being done, or not completing work. They need increased supervision because parents feel that they need to supervise the child more. That is, again, a source of stress. And then homework becomes a battle and daily stress. Parents strongly believe that it's because either they are lazy or they don't want to do it, versus they have underlying other difficulties. Academic underachievement, social difficulties, and family stress are among the most common impairment during this age. During school age, during 6 to 12, these are the most common impact of ADHD we see. Then we go to adolescent, 13 to 18 years, which is my favorite age group. One of the most common feature we see is hyperactivity becomes less obvious. So they're not as hyperactive. They're not moving a lot. Inattention becomes more persistent. So they're becoming more inattentive at this age. At the same time, emotional dysregulation increases. So you will see a lot of big emotions. They kind of either react to things a lot stronger, or not more emotional, or a little bit aggressive. That's why we talked about that earlier, that sometimes people miss that emotional dysregulation might be caused from ADHD rather than any underlying emotional disorder. And then greater impulsive decision making. So there's a clear differentiation between impulsivity versus hyperactivity. So in this age, you see a lot more impulsivity than hyperactivity. And one of the reasons is there is something we call teenage impulsivity, which from a developmental standpoint, teenagers are a little bit more impulsive in general. So given that they have underlying ADHD, that makes it worse. And we'll talk more about that. What are the impact of ADHD at this age? So, of course, the first one is education, because school is one of the primary things for them. So we see reduced academic performance, poor study skills. They're not being able to study well as they might have done in the past, risk of school failures or dropout. So a lot of the time, there's a very big pushback from the child for going to school because of the difficulties from ADHD. From a social perspective, again, they have difficulty maintaining friendships, increased conflict with authority. Again, remember, here impulsivity becomes more rather than hyperactivity. So impulsivity is there fighting back, talking back, getting into argument with authority figures. So we see that impact significantly. At the same time, there's a lot more emotional impact in this age group compared to other groups, because they're becoming more emotionally aware. So they have lower self-esteem due to the ADHD challenges. Anxiety and depression is very common as a comorbidity from the ADHD, and feelings of failure. Remember, they're becoming a lot more emotionally aware. So when they're not doing as well in school as others or as expected for themselves, the fear of the feeling of failure or the fear of failure becomes more evident in this age group. As I was talking about, that there is something we call from a developmental standpoint is teenage impulsivity, which we see this behavior in general, but especially with kids with ADHD, you will see a lot more driving accidents or risky behaviors. Like, for example, if they're legally not supposed to drive, but they might take their parents' car out. I have seen this a lot with some of my teenagers with severe ADHD, where they do a lot of these behaviors, risk-taking behaviors, and then experimenting with substance is another common issue that happens. And one of the driving trigger for it is the ADHD impulsivity aspect of it. Adolescence is often characterized by emotional dysregulation and increased risk-taking, as I said, teenage impulsivity, while inattentiveness symptoms continue to significantly impair function. So they have those impulsivity anyways, but if they have ADHD impulsive type, we see it more stronger and more difficult. Let's come to adulthood, 18 plus. So when you're an adult, the common features you can see from ADHD is persistent executive dysfunction. So you're not able to do your task and things well. Poor time management, which gets you in trouble in college, at your work, chronic procrastination, leaving things to last minute, not finishing things on time, and then internal restlessness rather than overt hyperactivity. Remember, when you're younger, you might be hyperactive, a lot of impulsivity, but as you become an adult, you're able to regulate that behavior on the surface, but internally it causes a lot of conflict and you are usually restless. The impact it has is on occupational functioning is difficulty meeting deadlines, or we always are the one asking for extension, or we get in trouble for that. Poor organizational skills, it's been seen across your academic, like college life, or when you start a job, and then frequent job change. People, you'll be surprised how many adults who comes in for ADHD assessment, this is one of the core symptoms they present with, and in the education part, they realized that that's what kind of the dot was why they were changing a lot of the jobs. And then underachievement despite ability. Despite being very good at something, they are not being able to perform at their best. Another key area which is compromised by ADHD in adulthood is relationships. There's a lot of marital conflict, communication problems, and forgetfulness affecting relationship. Your partner forgets something one time, two times, you can forgive them. But if they keep forgetting something that's important to you, it's annoying. And when we are annoyed by something, it leads to conflict. So again, it's like a domino effect, but it started from the ADHD. So it's not that your partner doesn't care and they forget, but it's because they have problem with forgetfulness. Again, impact on daily living is financial management difficulties, missed appointments, household organization. So you're not able to kind of manage your things day to day. What that does is increase anxiety because again, if you see yourself in financial troubles or other problems, it will cause stress to you, depression. Sometimes people are burnt out or substance misuse. In adults, ADHD is often experienced as executive dysfunction, organizational difficulties, and persistent challenge in occupational and interpersonal relationship. So if you just look at this chart from a quick standpoint, you could see how the area of impact is different at each age group and how the clinical manifestation is also different. But the ADHD is there. So it just changed the manifestation. And also at the same time, the reason for that is the area of impact. So for kids, for early childhood, it's preschool functioning and family stress. But if you look at adulthood, it's employment, relationship, and independent living. So you see how we are a different age group. The presentations are different. Just a quick touch on neurobiology of it. There's a lot of factors that's contribute to ADHD. So I want to highlight here that it's not causing the causality, but it's the contributing factor. So genetic is very highly heritable. So we always ask if any of the parents have the symptoms, and that also helps us kind of map where it's coming from. Brain structure and neurochemistry, as we know. Prenatal influences is a big one. There's a lot of research happening now about maternal health, maternal habits during pregnancy, and how that impacts the child. Prematurity is another factor, environmental risk factors, and psychosocial stressors. Again, sleep problem is a big one. There's a lot of research into that, and we will discuss briefly why that is important. And then gene, environment interactions. So these are some of the ongoing research area currently being investigated further for ADHD and how to kind of help and support that more. So sleep and ADHD. Sleep problems are common in ADHD. Poor sleep worsen attention and behavior. The most common issues, as we know, insomnia, delayed sleep phase, and sleep apnea, and restless leg syndrome. So these are some of the most common comorbidity with ADHD. Sleep disorder can mimic ADHD symptoms. So sleep assessment should be a part of every ADHD evaluation. Improving sleep often improves daytime sleepiness, especially in children. So as an adult, if I didn't sleep well last night and you are in a meeting with me, you'll see me dozing off or being very tired. Kids, as their brain is developing sometime, they will self-stimulate their brain and they appear to be a little bit more hyperactive. And sometimes we believe that they're having a hyperactivity problem when they actually are having a sleep problem and they're not getting enough sleep. Now, what does sleep do when you don't sleep well? Poor sleep, there's cognitive effects, right? Reduced attention span, increased distractibility, poor working memory, slower processing speed that we all go through if we don't sleep well. Behavioral effect, increased hyperactivity, especially in kids, more impulsive behavior, greater difficulty following instruction. Even as an adult, for us, it will be hard to follow instruction if we don't sleep well. Emotional effects, irritability, mood swing, frustration, intolerance, anxiety symptoms. If I didn't sleep well last night and something happened to me this morning that I don't like, I will be a lot more irritable than usual. And then functional impact, academic difficulties, poor school performance, increased family stress, and social challenges. If you're tired and you're not in the mood. Does it sound like ADHD? I would say if you look from the surface, it can sound like ADHD. And that's where we need to look into, is it ADHD or is there any underlying sleep problems happening? The next important thing I wanted to kind of highlight is trauma and ADHD. Individual who experience trauma may display symptoms that resembles ADHD. And individuals with ADHD may be also at an increased risk of experiencing adverse life events. The reason for that is the impulsivity or the poor decision making might put you in a risky situation. Now, just a quick clinical definition that what is ADHD? It is what is trauma? It is an emotional, psychological, or physiological response to an event, series of events, or circumstances that is experienced as physically or emotionally harmful or threatening and has lasting adverse effect on an individual's functioning and well-being. So when you go through something traumatizing, it can be physical or emotional. It can have a long impact on us. And that kind of can mimic ADHD-like symptoms. You would be surprised how many adult ADHD assessments I do where the diagnosis is a trauma, post-traumatic stress disorder, not ADHD. And I have to have this long conversation with the patient explaining the difference and kind of like the etiology of it and where the difficulty started and why it's trauma and not ADHD. An individual who is exposed to trauma may show these difficulties, right? They might have difficulty concentrating, they might be distractible because they're overthinking stuff, their hypervigilance, because they need to look for the next risky factor. The brain is kind of conditioned to look what other bad things can happen. Their restlessness because they're kind of hypervigilance. They can become a little impulsive because of the fear of the trauma. Emotional outbursts, we know, is a common thing for trauma. When you're trauma, you have difficulty with trauma, sleep problems are very common. And again, kids, especially kids who go through any traumatic experience, you will see a decline in ADHD. So it does sound like ADHD, but it's when we do a thorough assessment, we need to rule out all these factors. I really like this GIF on the right. It shows that the person who's running on a treadmill uphill can appear as a hyperactive person with a lot of energy. But if you look at the image from a broader perspective, there's a fire ring that he needs to avoid. There's also crocodiles in the back that he needs to escape. So is he really running up the treadmill because he has a lot of energy and he is hyperactive, or is it because he's traumatized and he's in a very scary situation? Now let's talk about the diagnostic essential. So multi-setting symptoms needs to be present. As I was saying, ADHD symptom must be observed in at least 2 settings, such as home and school to confirm diagnosis, or home at work. The reason for that is let's say you have or someone has the symptoms only at home, but not at school or not at workplace. Then the question comes, what is happening in that environment? What is causing these symptoms? Because the difficulty has to be across environment. Sometimes not having enough support, being in the wrong environment affects it. I always use the example of think of a cheetah and a monkey. A cheetah can never beat a monkey in climbing trees. It can climb some small trees, but not all of them. Vice versa, a monkey can run, but can never beat the cheetah in speed. So we need to know if this environmental things are fit. We cannot compare both those. So that's why we need to know that this is a difficulty that happens across the board rather than specific environments. Again, when you have the difficulty, there has to be significant impairment. Symptom must cause significant impairment in academic, social, or occupational functioning. Just because I have difficulty with attention, but I'm able to do my work, does not warrant a diagnosis or extensive treatment. It has to be a comprehensive assessment. So information, we need to gather data from multi-informant with interviews, rating scales, and observations. For pediatrics, we do with parents, we assess the child, we get school data. For adults, we kind of, if they're married, we with permission, we try to get information from the spouse. We give them some more rating scale to get information from parents or other family members to kind of track back the symptoms from early childhood. As I mentioned, the symptoms always starts in childhood, but looks different in adulthood. Always ruling out alternatives. It's critical to exclude other conditions like anxiety, trauma, or learning disorders before diagnosing ADHD. So the way the assessment looks like, the framework looks like is initially we do a clinical interview, depending on what brings the patient or the family in. We do a developmental and medical history, parent or teacher rating. Then for pediatric, we do school information review, and then we assess functional impairment, screen for comorbidities, and then we rule out differential diagnosis before reaching a formal ADHD diagnosis. It looks a little different with the adults, where we kind of do chronological assessment of symptoms through childhood, getting secondary information from parents or other family member who is available at best, and then kind of go from there. Now, in terms of management of ADHD, ADHD management is most effective when it's follow a multimodal approach. Remember, it's a multifactorial thing, so we need to have a multimodal approach to work on it. And we need psychoeducation, behavioral intervention, educational support for younger kids, psychological strategies, and then medication when appropriate. What determines if we need medication or more extensive intervention depends on the severity of symptoms. So if it's mild to moderate, psychoeducation and behavioral interventions and therapies are recommended. If it's moderate to severe, that's where its recommendation is to kind of seek medication with behavioral intervention and therapy. ADHD should be individualized and based on the individual symptoms, impairment, age, strength, and comorbidities. So that will determine if we need medication consultation or not. The first and the most effective intervention is psychoeducation. The first step in treatment is helping the child, family, and school understand ADHD. The key message is ADHD is a neurodevelopmental disorder, so it's no one's fault. It's not caused by poor parenting or lack of discipline. ADHD is treatable, and it's not a choice. I would want to also add that it's not a choice. Sometimes people miss that part. And children with ADHD have strength as well as challenges. Like I used the example of the monkey and cheetah. Like everyone has their own strengths and weaknesses. You would be surprised how many times when we reach a diagnosis and the parent understand that the child is actually having ADHD rather than a behavioral problem or anything else, it improves the child behavior, the parent's behavior, and the dynamic by 50%. What psychoeducation does is it reduces stigma, improves treatment engagement, and enhance collaboration between home and school, because now they understand what the child is going through. In terms of behavioral intervention, behavioral strategies are a core component of treatment. So at home, what we do is we put clear and consistent rules. We have structured routines. In assessment, we find out if the child is a visual learner or a auditory learner. So depending on that, we do visual schedules or other ways of reminders, breaking tasks into simple steps. Some kids benefit from immediate positive reinforcement. Others respond very well to token reward system. So this is where at the end of the assessment, we give the recommendation depending on the child's need and which one they will respond better to. Some kids does not do well with immediate positive reinforcement. Other cannot wait for the token reward system, and we need to know which one works for each. At school, preferential seating. So sometimes making them sit closer to the front, but closer to the teacher, that reduces distraction and easier redirection, task chunking, extra time for assessment and assignments. This is one of the most common recommendation and accommodation we do in school. And then frequent feedback. When they know what's happening, it helps them kind of turn the behavior quicker. Behavioral intervention help externalize structure and reduce executive functioning demands. Parent training is a very important one. It focus intervention help caregivers manage ADHD related behaviors effectively. What we focus on this is positive reinforcement from parents, consistent consequences the parents have to give, effective instruction giving. They have to really be mindful how they give instruction to the child so they can comprehend and follow through. Managing challenging behavior and improving parent-child relationship. Parent training is particularly effective for younger children. For this, we see the parents and work with them while they kind of provide the structure and intervention to the child at home. Rather than seeing the child, we work with the parents in this. School-based support, as I mentioned, many children with ADHD requires educational accommodation. So again, seating accommodation, movement break, written or verbal instruction, depending on the child preference, organizational support, reduced workload, and examination accommodation. The main goal is to improve access to learning rather than lower expectations. Remember, they are very capable. We just need to know how they will thrive. Psychological intervention. So cognitive behavior therapy is the evidence-based treatment for ADHD. Is particularly useful in adolescent and adult and any of the age group ADHD with anxiety or depression. So when you have a comorbid mood disorders. The target we do in cognitive behavior therapy is organization, time management, emotional regulation, and coping skills. So these are the 4 areas we work on in therapy with the patient and the family that helps them cope with their ADHD. Another thing that is very helpful psychological intervention for ADHD is the executive skill training, which focuses on planning, prioritization, task initiation, and goal setting. So executive skill training also shows significant improvement in ADHD management. For younger kids, which is more important than executive skill training, is social skills training, may help children who struggles with friendships, turn taking, impulse control in social situations. Remember, the impulsivity is stronger in adolescents, so social skill training is more appropriate for them. Executive skill trainings we usually recommend to young adults and older adults, which helps them a lot with their day-to-day functioning and relationships. Then comes medication. As I was mentioning, medications, when the difficulty is moderate to severe, sometimes we need the medication for it. There is the stimulant, which is the first line, and these are some of the types. The benefit is it improves attention, reduce hyperactivity, reduce impulsivity, improve academic performance. If you notice, it reduces hyperactivity and reduce impulsivity. So when there is a reduction in that, for behavioral intervention, we help them manage it more effectively. Now, again, stimulant is a stimulant, right? The first line of medication. So stimulant can have side effect of, if you have a comorbid anxiety, we see an escalation in anxiety. So in those situations, then there is a second class of medication, which is the non-stimulant. So if a child is put on a stimulant and we see clinically that anxiety is getting worse, instead of helping their ADHD, we send them back to the physician for another consultation. And again, these medications are considered if the stimulants are ineffective or side effect happens or specific comorbidities like anxiety or others. One of the most important things is medication titration and monitoring should always be individualized and under the care of a qualified and licensed physician, preferably a psychiatrist or a neurologist. That you should be under the care of one of these for this medication, while you seek behavioral intervention or support from psychology. One of the most important thing in management of ADHD is managing comorbidities. Treatment should address co-occurring conditions, anxiety, depression, learning disorders, autism, if you have an ODD, sleep disorders, or trauma. Comorbidities often influence treatment's outcome and overall functioning. Sometimes we see this, that a patient is going to one clinician for their anxiety or depression, and they see a new person at a different facility for ADHD assessment or medication without sharing the other information, or they don't go through a full formal assessment where that piece is missed. So it impacts the ADHD management because it's not effectively managed because the underlying or the comorbid condition has not been addressed at the same time. So a comprehensive assessment and management of comorbidities is very important for effective management of ADHD. Something that you guys can start from today, ADHD or no ADHD, is management, is sleep and lifestyle management. Sleep consistent bedtime routine, limiting screen time exposure before bed, and addressing sleep disorders is very important for our well-being in general, but especially for any ADHD-related symptoms. Physical activity. Regular exercise and structured sports participation. One of the Biggest intervention I always recommend, especially to children and young children, is physical activity. I always recommend parents to sign them up for sports. I have at least 45 minutes an hour of physical activity, and that does not mean playing in the backyard or just without screen time, but actually engaging in the sports. Healthy habits, balanced nutrition, daily routines, limiting excessive screen time is very important. Good lifestyle habits can significantly improve symptoms management. Remember, if you feel like you're struggling with any of the symptoms, just kind of doing these things for yourself will help. So again, a lifespan management of ADHD, if you notice for preschool, is parenting training and behavioral interventions. When we get to the school age, behavioral therapy. So I see a lot of kids for cognitive behavioral therapies and interventions. School support is very important. So I work very closely with the school, and then medication when indicated, when the difficulty is moderate to severe. And usually when my kids are almost at the verge of getting either expelled or any other troubles, and therapy is not making enough progress, that's where I would refer them to the psychiatrist or the pediatric neurologist for consultation. Adolescent, again, cognitive behavior therapy works very well. We do some executive skill training if there is no social skill training needed, and then academic support. For adults, again, cognitive behavior therapy, coaching, workplace accommodation might be needed, and then medication if indicated, if the difficulty is moderate to severe. Now, there are some apps that can help us in terms of support us. So again, remember, these apps do not treat ADHD, but they can serve as an external executive function support by helping individual manage time, organization, routine, and attention more effectively. So for time management, the time timer app, as you can find on the App Store, is very good. Forest is another good one. For organization, To Do is a good one. Microsoft To Do, Trello, Notation, these are very good ones. For focus, Freedom, Cold Turkey, Focus To Do, these are some apps you can try which can help you train your focus. Sleep, Calm, Mushi, and Headspace. Headspace is a very well known in the field. That helps with kind of like some of the sleep difficulties, and it has prompts to walk you through to calm before sleep and things like that. For mindfulness, Smiling Mind and Headspace is another good one. And then for parents, ChoiceWorks and Behavior Tracker Pro is a good one that will help you kind of work with your kids, kind of help them track their behavior and kind of like guide them accordingly. That will be it. That will be the end of my presentation. Let me stop sharing and then turn on my camera.
Thank you, Dr. Habib, for the informative presentation on understanding ADHD. We will now move on to our question and answer session. So, Doctor, for first question that we have, what's the biggest misconception about ADHD?
So one of the biggest misconceptions about ADHD is, like I mentioned, and I didn't put in writing, is they believe it's a choice than a condition. So a lot of the time, especially in kids, when they come into clinic, they've been through a lot of hardships, the hard time given by the teachers, by parents, it's been labeled in different ways before they realize that actually they have a difficulty, a challenge. So kind of that psychoeducation aspect and removing the stigma is the hardest part.
Thank you, Doctor, for answering that. Moving on to the second question, why are some people diagnosed with ADHD later in life despite having symptoms for years?
Lack of awareness. So lack of awareness is a very common one where people get diagnosed later, because that's when they find out that, okay, my challenges, or this makes more sense to me. So if someone described to you inattention or symptom, and then you realize that, oh, this is something I've been struggling when I was a teenager, even though it was very hard to finish high school and in college, that's when they come and seek assessment. And that's one of the most common reason I see young adults or adults for ADHD assessment, that they realize that someone told them that they should get assessed for this, because this might be what's causing it to them.
Thank you, Doctor. Moving on, how can parents distinguish between typical childhood behavior and signs that may warrant an ADHD assessment?
So one of the most common thing, as we mentioned, one of the most important thing for ADHD diagnosis is it has symptom impairment has to be across different, at least two settings. So for kids, it has to be school and home or social, and then for adult it has to be occupational and family. So if a parent is seeing a difficulty at home, but when they ask the teacher, that's not reported at school, or vice versa, we see it when parent brings a child for assessment and there's a difficulty reported by school, but the parents are not seeing that. And then we see that, okay, the child has an underlying learning difficulty, or something is happening, or bullying is happening. So the first thing the parent has to do is the same thing happening in school as well as at home?
Thank you, doctor. And moving on, what challenges do females with ADHD face that may differ from those of males?
Inattention. So ADHD, as I mentioned, inattention, ADHD inattention is the most underdiagnosed difficulty because these individuals are labeled as lazy or not interested or not living up to the mark. But especially because, as we know, in teenage, generally boys tend to show more externalizing behavior, aggression and things. Girls show a lot more internalizing difficulties with low mood and things. So when so the same thing happens with ADHD is girls tend to have more inattentive type, and that's what gets missed most of the time.
And doctor, another question. How does ADHD affect the child's learning and reading capabilities?
So if it's ADHD alone, it does not compromise their learning or educational capability. We just need to attend to it. So, for example, some of the kids who has ADHD, they might need a quieter area to attend. They can perform at the same level if their IQ is average or above average. They will get those grades, but with that support, we need to have a quieter area for them with less distraction and things like that. Now, if they have any comorbid underlying learning difficulty, we need to just kind of rule that out and kind of make the ground fair for them.
Fair point. And lastly, doctor, the last question that we have for today, what practical advice you would give to someone newly diagnosed with ADHD?
So one of the most important thing when the new diagnosis happens is understanding what type of ADHD. Is it ADHD inattentive type, comorbid type, hyperactive type? So once we understand that aspect, we need to kind of look more into, okay, what kind of intervention will work for that child. As a professional, even when I give recommendation for, let's say, hyperactive type to the parents, they know best what happens in the house and what happens in real time. So I always give them a task that, okay, I want you to go do an independent assessment of the house environment and how we can, I'm telling you what the problem is. Now you tell me how does this problem plays out at home and what are some solutions that because I'm not in the house environment, that I don't see that you can see. So kind of teaming up with them, empowering the parents or the adult to kind of actually problem solve with you rather than kind of this feeling of helplessness that comes with new diagnosis that takes over. So that's the first thing we need to do, is to stay away from that feeling.
Thank you, doctor, for the thorough explanation. With that, we will wrap up our Q&A session. Thank you once again, Dr. Habib, for sharing your expertise and valuable insights on such an important topic.
Thank you, Brahma. Thank you for having me.
And to our audience, we have now reached the end of our webinar. Thank you for joining us and participating. Please take a moment to answer the questions. Your feedback and inputs are appreciated. Thank you all for joining us, and we will look forward to see you, inshallah, in upcoming webinars. Stay safe and enjoy the rest of the day.